Hi, my name is Asha Devereaux, and I'd like to answer some questions about Omicron that many of my patients have had over the last few weeks. We will first start with describing the situation currently, nationally as well as locally, discuss some of the questions that I've received regarding infection and quarantine, as well as masks, COVID therapeutics, vaccination and the fourth dose, and what is the prognosis of travel. I put this picture on the right-hand side of a visual of consideration of the virus and our masks, as Omicron now is much more transmissible and persists in the air. Also, we are having a current surge, and many of the hospitals are having staff shortages. And that is something that is very important to keep in mind going forward as we try to avoid getting this infection, which may feel inevitable, but we have to keep in mind we want to be able to receive medical care in a timely manner. So, the current situation is one of rapid and accelerated growth. On the left-hand side, we had a presentation that I gave last month where South Africa was the predominant location where Omicron was found, and the rest of the world was not significantly impacted in late November. Come forward to January, and the entire planet is seeing the surge in this genetic variant. On January 12th, the WHO predicts that 50% of Europe will be infected with COVID if the current coronavirus trends hold. Interesting, on December 7th, on my last presentation, there was this image that I showed showing that there was signs of growing Omicron spread. However, crowds were still outdoors and gathering. In early December, the predominant strain was the B.1.617.2, which is the Delta. And fast forward just 4 weeks later, we are seeing that Omicron has overtaken Delta in the United States. Let's look at San Diego County. And this is Dr. Eric McDonald, who is the county chief medical officer. And he gave a presentation to all the doctors in San Diego a few days ago. It shows that our current caseload to the right is on an accelerated curve upwards. There are some dips depending on reporting, but we just don't know right now when this will peak out, so to speak. So right now, this weekend, we are in our predicted and modeled peak period. In San Diego, as well as with the rest of the United States, we are considered in a high level of transmission. Our weekly case rate is about 2,289 per 100,000 cases, and our test positivity rate is 27%, over 27%. Interesting, compared to the rest of the United States and California, we are much higher. Why is that happening is one question for us all. This is Dr. Shao, who is an infectious disease specialist in South County at Sharp Chula Vista and Scripps Chula Vista. And the Sharp Hospital System plots their COVID hospitalizations by location. You can see that we are in our current wave going upward. And at this time, Sharp is being able to distinguish between Omicron and Delta by the S gene failure or the S gene transcription dropout that we see in the PCR testing. And they found that to correlate with Omicron. And they estimate that 25% of current cases at Sharp are Delta. So it's defying that first image I showed you earlier from the CDC. So here are some of the questions that came through on quarantine and testing from you all. After someone has COVID for a period of time, do they have to be tested to determine if they are no longer contagious? How long should they quarantine for or after they are feeling better? How long can they carry this bug after they test positive? And then this was a specific question, but it's very common. You can, for somebody exposed at home, my housekeeper's daughter wasn't feeling well, tested positive. Then the employee took a test. She had no symptoms, but was positive. So when can I have my employee back? So the rapid antigen test versus the PCR. Let's talk about testing. So what's commonly sold in the pharmacies and what's considered the rapid test is an antigen test where it reflects your body's response to the live virus while it's there. It is only about 66% sensitive. That means that it will miss about 35–40%. So it is definitely dependent on if a person has symptoms and how much virus is present in their nose and how much of a um, immune response the individual is having. False negatives and false positives have been noted. The PCR, the molecular test, is highly sensitive for the coronavirus. And as I mentioned, that S gene dropout reflects and correlates with Omicron. Proper collection of either specimens is the key to a good test result. The molecular test detects asymptomatic people, whereas the rapid antigen, you need to have some type of a response to be detected asymptomatically. With Delta, it was a lot easier, but with Omicron, it's more difficult. It's important to keep in mind that these rapid antigen tests, the reagents or the liquid that allows the test to turn positive, was created against the wild type coronavirus, not Omicron. So that's why it's taking a little bit more of that virus. It's presumed that it's taking more of a viral load or more of a response in order to be picked up on the rapid test. The PCR molecular test is not rapid. It takes a few hours to be run in the lab. And right now, turnaround times are ranging from 24 to 36 hours, just due to the sheer volume. These tests can remain positive for 30 to 90 days after a person's been infected. So it is advised not to retest using the molecular test. However, if you are positive with the rapid antigen test, you're feeling sick, and you want to know, it's been 7, 8, 9 days, and you want to know if you're still shedding virus, then it's okay to take the rapid test. Here is a rapid test at day 5 of a person with active COVID a week ago, and then or 2 weeks ago, and then here is the test result at day 10. Interestingly, this person remains still weakly positive, so perhaps there is still some viral shedding. This individual had only received 2 vaccines, so the booster hadn't been administered yet. So perhaps that might reflect this person's prolonged shedding of virus versus somebody who may be triple boosted. I think the data still needs to be done. We're still waiting for these, why these are happening. Omicron is currently estimated to be 4 times more transmissible than Delta, and we still have found that the vaccines are protective from hospitalization and death, but not infection. Whereas with the vaccines, the boosted doses were pretty effective in preventing infection with Delta and the wild type. There was a recent preprint out. I couldn't quite locate the reference, but I saw a study that showed that it is estimated that Omicron may persist in the air in a closed room for approximately 20 minutes. So it's very important to be careful if you are in locations where you do not know who's been there before you, because they could have been potentially infectious. And if you walked right in, like a public bathroom or something, so please make sure you are wearing a good mask. In the UK, the reproduction rate for Omicron was determined to be about 3.7. That means one person can affect almost four people. I alluded to viral load and shedding. Those are two things that can impact your test positivity as well as symptoms. So, the amount of virus you may inhale will determine positivity and symptoms and the timing of that. Your underlying host immunity also determines your response to the infection, your duration of illness, and duration of transmission. So, if you are potentially immune compromised, you may have a higher viral load and you may transmit the virus a little longer than an absolute number of 5 days, 7 days, or 10 days. Your vaccination status also likely determines your duration of transmission. We know that unvaccinated individuals will shed virus a lot longer than vaccinated individuals because they can fight off that virus and kill the virus a lot faster. And it this time, the rapid antigen test likely correlates with probable live viral transmission. So I would not use it as screening regularly, although it is currently being used in that manner, because we have seen people with symptoms day one test negative, day two test negative, day three after they've had more viral replication, then will test positive. So you may feel falsely reassured if, with a negative test and a runny nose and say, blame it on allergies. But once you have been confirmed positive with COVID by PCR, you might be able to use a rapid test to determine when you might feel safer to exit quarantine day 10, 11, 12, depending on your vaccination and immune status. So let's talk about testing and test kits. And I know they're very hard to get. The White House announced this week that they are going to open a website on January 19th to register for free at-home COVID-19 tests that will be delivered to you with no cost. You need to just sign up. No credit card or other information is required. It is going to take 7 to 12 days to reach you, 4 kits per household. They will plan a phone line for people, internet and public outreach groups to help people who don't have either a phone or internet. Their plan is to first distribute to low income and highly impacted areas. According to this news release, the government currently has millions of tests available. I don't know why they didn't release it last week when we're currently, as you can tell, in our upswing for the surge and people need to know. And so that's a question I have. And then instead of making everyone register and then wait 7 to 12 days, when that's probably the entire time course for a COVID infection, why not just give it to all the postal services and have the mail carrier drop at each resident? These are just my own personal thoughts, not anything formulated by any scientific individual. I think that on the 19th, the website likely will get overwhelmed. I also believe that it is winter. We may see some delays in shipping. I also stand by the fact that if you test positive, by the time you get these test kits and need it, it may not help you. And it's not likely to help if you're using it to screen weekly. But it is a good confirmation of clearance of virus if you've been previously positive and symptomatic. So, your questions based on all of that information. After someone has COVID, do they have to be tested to determine if they are no longer contagious? There is no need to test if a person is asymptomatic and it has been 10 days since the onset of symptoms and they are afebrile and they really don't have significant cough or other symptoms. If you're a healthcare worker, it's a different story. I'll show you a slide next on what's going to happen to those in healthcare due to the workforce shortage. If you're immune compromised or unvaccinated, then definitely recommend the antigen test to see if you are still infectious beyond those 10 days. How long should you quarantine after you're feeling better? 10 days total after onset of symptoms is what is advised by me. The CDC are using 5 days, but if your antigen test is still positive, I recommend continued quarantine and wear an N95 at all times since you will be likely infectious. And that's, I think, the caveat on the CDC's recommendations. They say you can go out at 5 days, but you have to wear an N95 at all times. However, we have witnessed people wearing their masks with their nose above their mask, so that would not count. How long can you carry the bug after they test positive? 10 to 14 days seems to be the average, although there will always be exceptions to every rule. And as I mentioned, depends on many other factors, which would make you be able to transmit the virus a little longer, like underlying immune status. The question regarding having somebody who works for you exposed at home, and then when can they come back? There's a lot of other questions that are layered in here. And one of the questions I have is what date did the daughter start feeling bad? If that daughter is considered infectious at least until day 7, and then the mom would have to start her time course for being negative about 7 to 10 days after that. Or if that housekeeper remains negative, and rapid test is negative. So there's a lot of what ifs in that question. So I couldn't give you quite a clear answer, but it all depends on onset of symptoms and then when the daughter might test negative and then go 5 to 7 days beyond that. And if you're going to involve testing and whether the employee develops symptoms or remains asymptomatic. Now, if you're a healthcare worker, and we are currently, and many hospitals are in a healthcare worker shortage with hundreds of people calling in sick. And with these peaks of people needing hospitalization, not necessarily always due to COVID, but COVID may trigger other problems like heart failure or exacerbate underlying illnesses. That's why hospitals are incredibly busy right now. So right now, the recommendation in many facilities is that if an employee is fully vaccinated and not yet boosted or eligible or has been boosted, and they don't feel very symptomatic and they want to come to work, they can come to work at day 5 as with the negative antigen test or at 10 days without the test. If you are coming to work, an N95 equivalent should be used between days 5 and 10 if you are coming to work. And you should eat alone until day 10. And that is the standard for all of the recommendations. Now, if you're in a real bad crunch, then the recommendation is you can come back to work at day 5 with the most recent test, even if it's positive, and try to place your staff in the COVID ward, taking care of COVID patients. And just to let you know that Sharp won't be following the similar protocol. They're going to have not have employees who test positive and are feeling ill or even still positive come to work. So it these things seem to be catching a lot of people by surprise, but I can tell you that ever since the onset of the pandemic, the only certainty is change. We must have flexibility and humility in medicine in the face of uncertainty and learn as we go and accept that those changes will happen and roll with it. We do know that with proper masking and shielding, healthcare workers are able to keep themselves safe. So let's talk about how to keep yourself. For over since the beginning of my career, we've been in a variety of different respirators. It's interesting now that we are having to kick it up a notch. Cloth masks, I can tell you personally, will not work. My own son got COVID through a cloth mask, and he was diligent about wearing the mask. So masks are not perfect if they get wet, if they are porous. And so the more impervious you are, the more protected you are. So you're practically in a hazmat suit, which is called a PAPR. And they are very comfortable and can be worn up 3 to 4 hours at a time with their battery life. There is a N95 equivalent or even a 99% equivalent filter in here. It brings in air through here, goes through the filter system, and then comes around your face. The downside is that they are very expensive, and it's not something that would be used outside of a medical environment. One of the questions I received, what do you think about the N95s that have a fan? So extrapolating from the pepper and bringing it to everyday use sounds like a great idea so that it keeps us cooler and more comfortable. But a concern by this individual was that the fan could bring in more air and then more COVID virus. And is this UV light that's in there a joke? Well, early in the pandemic, we were installing UV lights everywhere in the hopes that it might help kill the virus. Before we knew that just plain soap and water would kill the virus, and that the virus can desiccate within hours and die. So the UV light likely will work, but I think if you have a good filter on your mask, it would be fine. This mask here has just a porous filter with the fan built in, is being advertised as a smart mask, which with an air purifying smart mask. This is on Amazon. However, it does not identify itself as an N95 equivalent. It's just as a comfort mask. So I would think that it would meet your concerns, that it would bring in more virus. This attachment, on the other hand, has a small thin filter in front of the fan, and it says put this on and then put your N95 in front of it, and we will keep you cool. So air would come through your N95 through their internal filter, and then to your face, you exhale. There's the exhalation port, and carbon dioxide would exit. That in theory seems like a great idea, but I think putting an N95 over this, and if this isn't a good seal, or if this isn't sealed around here, you could get Omicron over your mask and into your mouth. So your concerns, the individual asked this question, the concerns are still very valid. My preference would be an N95 filter equivalent sealed around this to then really ensure. But then this replacing this filter would require a little. Are all N95s the same? No. There are KN95s and the Korean KF94. Some of the older KN95s that were manufactured did not pass our NIOSH ratings for adequate viral filtering. They may be considered knockoffs. If these straps loosen up and air comes through here and they're not fit properly, you can still get infected. Masks that are rated N95s but have a valve in front of them will allow virus to come through. These are N95 particulate matter filtering masks, but for viral entry, we have to keep in mind that if the masks are loose, they get wet, they get soiled, they get cracked, viruses can enter. So the good mask is one that has a NIOSH N95 rating. The CDC and OSHA, I believe, have a website up where you can type in the numbers, but if you see a NIOSH rating on the mask, you are okay. And so look for that in any mask you buy. I have to tell you that this is the one that I have been fit for. Uh, and the fit test process is extensive to make sure that no fumes can enter through this mask. And this one is quite about $500 for 200. So it's about $2 a mask. And prior to the pandemic, they were under $1. So let's talk about therapeutics now. If we get COVID, will I be able to prescribe you monoclonals? Here are the current monoclonals. This is by the County of San Diego. And I have to admit that the slides from many of these slides were all taken from presentations by the CDC, IDSA, San Diego County Medical Society, and the county over the last 10 days. And I thank them for sharing all their knowledge with us so I can share it with you. So the monoclonal antibodies are bamlanivimab, etesevimab, casirivimab, and devimab, or the Regencov. And these two you're going to hear more about, so sotrovimab and Evusheld. These are the ones that are felt to be most effective against Omicron currently and highly limited. These two rapidly ran out in December due to the increase in caseload, and so no longer are being even provided for what we call post-exposure prophylaxis because they are predominantly active against Delta. And you saw the current numbers by the CDC estimating 90% and upward are Omicron, although our system says there's still some Delta around. But it's very difficult to get those rapid results to know whether it's Delta or Omicron. So sotrovimab is very limited. Sharp Coronado is not going to be able to administer monoclonal antibodies. So in answer to this person's question, Evusheld is a monoclonal antibody that lasts 6 months, and it's for pre-exposure prophylaxis for immune-compromised individuals. And just this week, we will have 72 doses to administer, and there is going to be some criteria that I will go over on who gets it. Other therapeutics, though, we may have some access to. Paxlovid is the Pfizer drug, and that is considered first line. And then there is a drug, molnupiravir. We'll talk a little bit more about that in a few slides. So how do the monoclonal antibodies work? It's important to know that it must be given within the first 10 days of onset of symptoms. So it is important you let your doctor know as soon as possible when you are feeling ill so that we can get you in the queue for treatments if you qualify. According to the NIH guidelines, these are all the folks who are a priority for monoclonal antibody therapy, especially if there are any supply shortages. But they've even narrowed this down further, as I will explain in a little while. So the monoclonal antibodies work. Here's the spike protein of the coronavirus. And we have these antibodies that we make if we have a vaccine, and they're floating around in our system. So just in case the virus comes along, we will grab onto them. Well, immune compromised folks, when we've discovered get the vaccine, they don't mount this antibody response. So we need to provide that antibody. That antibody will then be circulating in the person's bloodstream. You have the virus active, or you may be introduced to that virus later down the line with Evusheld if we've got that on board. And it will, these antibodies will latch onto the virus, bring it to your cells that are like Pac-Man and chew them up, or these antibodies will stimulate what we call cytotoxicity and send out some enzymes that will then kind of punch holes in the infected cells and kill the infection off. So there's a variety of ways that the antibodies will help your body fight the infection. Let's talk a little bit about Evusheld, which was just approved in late December. And it is a double monoclonal antibody against the SARS-CoV-2 spike protein. And it is advised to give for immune compromised people who are not currently infected by the virus and who, or for whom vaccination with any of the COVID vaccines was not uh, possible due to an adverse severe reaction. And there are folks out there that meet these criteria. And there are very specific immune suppressive conditions like lung transplant, solid organ transplant, untreated HIV with cell counts under 50, certain specific immune depleting diseases. So what's happening now is you have to meet the tier criteria in order to be eligible to receive Evusheld. And we will be submitting those paperwork for those individuals. At this time, due to the staffing shortage, Sharp Coronado won't be receiving this drug to administer. So if we look at, in answer to that person's question, what treatments can you receive? The NIH has prioritized certain treatments in this order, and based on relative risk reduction and accessibility. So the first choice would be the Paxlovid drug. It decreases our risk for hospitalization by 88% or death. It's highly efficacious. It's one part of the drug has been studied in pregnancy. The problem with it is there are many drug-drug interactions, and I'll show you a list in the next slide. The next would be the specific monoclonal antibody that works against Omicron, which is called sotrovimab. That's highly effective, prevents hospitalization or death by 85% risk reduction. It's safe in pregnancy and no drug interactions. It's a 1-hour IV infusion. However, our current supplies are very, very limited. And it requires staff to administer, and we're across all board. The staff we have a staff shortage. The next is old drug in COVID times called remdesivir. It was used for hospitalized patients, but there was a study released in the New England Journal in late December that showed if this drug was given to outpatients within the first week of their symptoms, that in over 3 consecutive days, that it dropped the risk of hospitalization by 80 to 87%. So it's 87% risk reduction for hospitalization. Very little drug interactions. I've used this drug in COVID, and it was easy to use. We do watch the liver tests for the drug, but at 3 days worth, probably we wouldn't need to. And the main caveat with this drug is that the way the FDA approved it was for only administering in the hospital setting. I would love to be able to provide this drug through home health nurses or delivering outpatient pharmacy nursing support. And but because of that, it's considered off-label. I believe the FDA will be meeting in the next couple weeks to approve it for outpatient use, and then I hope to see this as another tool in our toolbox to get through the next 6 weeks to 8 weeks. Molnupiravir was the first out the gate as a oral treatment for COVID. However, it's only a 30% relative risk reduction. So it is less effective than all the others, but we have tons of doses of this. If we couldn't get any of these, then we would choose this. And it's not recommended in pregnancy or children. So unfortunately, we have a lot of this or access to this, but I don't see us truly using it if we've got 1, 2, and let's look at Paxlovid, which was considered #1 choice, and it is recommended by our county to go to this drug first just because of the supply shortages of the monoclonals. There are many drug-drug interactions, and we here is just a partial list. Many people are on cardiac meds or Plavix or clopidogrel or statins. That's probably our biggest and most common medication that would flag a drug-drug interaction. With statins, you could hold that drug for 5 days while you are taking Paxlovid if you had COVID, without significant harm to your long-term lipid profile. So I recommend that's what I would do. Some of these other cardiac medicines, it would be very difficult to stop without creating an arrhythmia, and we wouldn't want to do that. We'd probably switch to a different agent to help with you with your COVID. If you have renal dysfunction, there is a dose modification to one of the drugs, but it's not impossible to provide you treatment. You may see nausea or vomiting if there's a drug-drug interaction, so definitely report that if it. So here is the priority group on how treatments, whether it's the Paxlovid or Sotrovimab, is provided. Is if you are immune compromised and you're not expected to mount an adequate response, you're a tier 1 or unvaccinated at high risk for disease, or any unvaccinated individual over 75 or over 65 if you had some of those other diseases I had listed on that first slide on therapeutics. And then you go down with tier 2. So the unvaccinated and immune compromised are the first 2 tiers, and then vaccinated at high risk or who haven't received a booster are tier 3 and 4. And it just will depend on where folks fit into the tiers. So let's talk about what does it mean to be vaccinated. As we know, the variants seem to be easier in transmission and infectivity. And back to the slide, respiratory droplet and airborne transmission are methods of infection. Vaccination with the current vaccines and the booster doses likely decrease the risk of death, but we'll still be at risk for symptomatic Omicron. And most folks who have been getting it, and believe me, I'm telling folks every day that somebody has COVID, after the fact, they said, this is worse than the flu. It's not worth getting this sick. So, what do you think about the new Pfizer vaccine against Omicron, and when will it be available? Should we get the 4th dose of the current or wait for the new vaccine? So, let's look at what the original vaccine Pfizer, Moderna, Johnson and Johnson was created against this wild type coronavirus. 2 doses were very effective against this first virus, and 3 doses were as well against the wild type. Now, this is all in lab studies. Then you look at the Delta mutation, and we started seeing breakthroughs after this in this double dosed regimen, and that's when the 3-dose vaccine boost came up because we saw that at a certain period in time, our immunity waned. It seems to, and I'll show you slides about that. But having a third dose did help achieve protection against Delta. With 2 doses in Omicron, there's definite breakthrough. But in this lab study, the third dose helped neutralize the Omicron variant. However, as many people can attest to, they've had 3 doses and they have gotten infected with COVID in the last. So let's look at vaccine effectiveness. The primary series, which is considered 2 doses, there's been 4 studies and some looking at hospitalization. So the variety of studies are a little all over the place, but it was anticipated that the vaccines still are very effective, 50 to 60% if you've had 2 doses against hospitalization, but everyone still can get infected. They're only 20% effective against Omicron infection. If you get boosted, you may boost yourself up to 50 to 80% protection against Omicron, but definite 90 to 100% against hospitalization, but we can still see some form of infection, symptomatic disease. In the US, Moderna vaccine effectiveness against Omicron, 2 doses drops to 30% after about the at the 90th day. Delta still maintained a good amount of protection. Third dose does boost you up to 60%, 62%, but let's look at the immune compromised. They're at only about 11% protected against infection. In the UK, this is a really nice study, or a nice slide that Dr. Hill presented from, and she's an infectious disease physician at UCSD, that shows that 2 doses of their Chadox, or I think it's the AstraZeneca there, showed that by week 28, you're at 0% protection against Omicron. You still have some protection against Delta at about 40%. Then you get the third dose with the Pfizer drug. You're boosted against Delta. You're at best at 10 weeks, you're at 40% against symptomatic disease for Omicron. Boost with the Moderna, you're near 100% against Delta, and at about 9 weeks, because that's how long this study was run before they published something, you're at about 60% against symptomatic Omicron. Now, 2 doses of the Pfizer drug or the BioNTech, or the drug, again, similar data. You get down to 0 against Omicron, get the boost, you get a little bit of a bump up that lasts about 10 weeks, and then the downward curve. We just don't know where that's going to go, when it's going to go down to 0. And get the Moderna, same thing. We just don't know the delay or the lag, how long it will remain efficacious. We're waiting for more from the Moderna vaccines trials on how a boost third dose will work, but time since the second dose at 25 weeks, we're at 0 against symptomatic Omicron. So boosts do help get you through. You may still have symptoms, but it may be milder. So when can I get that additional boost, even if you've gone through the full dose for the first series? If you have been immune compromised, your series is considered 3 doses. So this fourth dose will be your booster, and that was approved last week by the CDC. So anybody who's immune compromised and went through their first series is eligible for their booster, or known as the fourth dose. And for the rest of us, I don't know. It's not authorized for us to get a fourth dose yet. And whether even what it will do for us, because if we are still at this stage, we don't know from if I had administered Moderna to most folks, where you're at here. Are you still here at 12 weeks? So getting a boost to just stay neutral? I don't know, a fourth dose for that. Because remember, it's against the wild type COVID and not the Omicron. So let's look at potential Omicron specific vaccines. So Peter Hotez and Maria Bottazzi at Texas Children's and Baylor have been studying this quite a bit, created a vaccine against the Omicron spike, and it looks like that it was greater than 90% effective for prevention of symptomatic infection against the wild strain and against 80% against Delta, and it did not significantly drop with against Omicron. So well tolerated and fairly inexpensive, and India has approved it and it's being sold there. There's other vaccines in India that may actually be working, and they may see a surge. And so let's see after their big holy festival this weekend and see what happens there, and we'll get an idea of the efficacy of these vaccines. For Pfizer has announced that they anticipate their vaccine directed against the Omicron variant, that recipe to be out sometime in March. Likely, probably we'll get into our arms in April if we're lucky. And if people want it, it's important to keep in mind right now that only about 30% of San Diegans have even received a third dose. Moderna says that their newer formulation will be out in the fall, and I don't know if it's just an Omicron specific recipe or they're doing something different. So more to follow. I apologize, I don't have a great answer for those who are not immune compromised, whether you should get the fourth dose now, which you're not eligible for according to the current guidelines, or do you want to just wait? So the next question on everybody's mind is, can we travel? This is a picture that I kind of blew up that was on social media last week of a person who was texting this. Somebody took a picture from the seat behind this woman because she could totally see her texts. And this woman was typing, "We have COVID. Shh, that's why we're on a plane returning home, because I'd rather be at home." So people are traveling as as recent as January 8th with active COVID, knowing they have COVID. I doubt this person has a well-fitted N95 on, and I bet they probably pulled the mask down to drink a sip of water or eat. So those would put those at least within the 2-seat radius around her at risk. So when can you travel and how should we kind of navigate these roller coaster waves, so to speak, of surges. And my recommendation would be to take a look at these peaks and valleys of your current environment or your location, as well as your destination, and try to predict travel when there are less than a 5% prevalence of COVID in that destination. Many times you may be leaving uh, our city when we have a higher incidence and going to a place that has a lower incidence. Be flexible during travel and be prepared that you may get infected while you're overseas or somewhere else, and that you should anticipate some quarantine period in there. My recommendation is if you have an N95 and a good face shield, you can pretty much travel and do anything with confidence. But be careful. You don't want to remove it for food or water until you're in a safe place, just because you don't know who's sitting in front of you or behind you in your plane or train that may actually have an infection that can pass on to you. I got a series of questions on activities and transmission risks. A lot of people are wondering right now how to gather with friends. Do you do it outside? How far apart? Do we wear masks inside? Should we get together for meals? What about testing? Do we have any idea on numbers? How about going to people's homes or having guests? In answer to that question, I think I've given you some suggestions regarding testing. PCRs would be tough. If you did one the day before, you have to make sure you see nobody for the 24 hours prior to that event, that to guarantee that your negative test will remain negative. If you want to get together with folks outside, right now with 27-30% of tests being positive, and how much Omicron can persist in the environment, I would be cautious. Wait for a couple weeks. Number of people, well, it only takes one infected person to now infect four. So we have to realize that right now, a lot of kids are coming home from school and the entire household is getting infected. So we need to be cautious, at least for the next week to 10 days. And having friends stay with you depends on how they arrived. If they drove from their home to yours, likely that's considered a bubble and they should be fine. However, if they took an airplane, that is what I'm finding. A lot of folks are having house guests. People flew in, and then after their 3 day stay, they're getting the phone call that they were pop positive. So it's something that is real and impacting many of you. What about appointments, massages, hair salons? Is it safe if masked? Sure, if you wear your N95. How about medical appointments, dental appointments, derm appointments? My recommendation would be if it's absolutely necessary, you have a broken tooth or an infection or something like that, or a malignancy, wear your N95, but some of those you can't, and you might be exposed to a healthcare worker who is asymptomatic and possibly may transmit disease to you. So for the next week or two, at least make sure it is absolutely necessary. Eating at restaurants, many people say, when is it safe? Many people haven't dined indoors for 2 years. What about outdoors? At this time, even it depends on how spaced out the tables are, whether you're comfortable being outdoors, and what type of mask will you wear. And make sure you put your mask on when the server comes, because if they're wearing a cloth mask, it's not effective. Are we safe outdoors again, but in a different way, moving? Walking, bike riding, playing pickleball, yoga, all of those look like they are very socially distanced activities, and you are likely just fine unmasked. However, if you're walking and a group of people just walked in front of you, coming at you, and were unmasked, knowing what we know about Omicron, I would carry a little lightweight N95 or just a paper mask, quickly put it on so that you aren't exposed. So in summary, Omicron is on the rise, has taken over the Delta variant. The monoclonal antibody of choice is sotrovimab, 1 hour infusion. Our antiviral medications, this is Paxlovid. It's 3 tablets twice a day for 5 days, so 6 tablets a day. And it is our drug of choice right now. There is a new monoclonal on the market as of December 8th, but it's just arriving to San Diego this week, called Evusheld. It is for our immune compromised. An infusion will last you 6 months of protection, so it's kind of like a IV vaccine. And then what about all the questions about vaccines? 3 doses, definitely. We're only at 30% in San Diego in terms of third dose administration, so I would get boosted if you haven't been. And then regarding the fourth shot, yes, if you're immune compromised, I reserve my opinion for non-immune compromised for a little while longer, just because we are seeing that people who have been triple vaccinated are tolerating Omicron quite well. And we don't know that the fourth dose will change that. I did receive some questions regarding unproven treatments, especially ivermectin. And please, please, please don't be the first one to use an unproven treatment. Like what Paul Merrick, who's in my pulmonary critical care community, was highly regarded. However, in this instance, he's lost his job at his hospital and is just running this COVID treatment network. If they really worked that well, this pandemic would be over by now. And I think that's something to be said. I have treated lots and lots of people who were on ivermectin and they got COVID. So I don't think it's a perfect drug. And we have some others out there that we know are 80 to 90, 80, above 80% effective in protecting you against hospitalization. So until we know more about all these questions, everyone should just still stay with this. This was one of the early CDC slides from 2 years ago. Even after vaccines, still do the same simple mask, distance, avoid crowds with unknown people, keep your hands clean. My thought is that we're all going to get infected. We just want to delay that day so that we can have a treatment if we need it. And our next seminar is going to be on hair loss with a special guest. I thank you all for your attention and wish you good health until we meet again. Take care.